first to do a human notes procedure with the PEG rescue. So why haven't you moved on to bigger and better things?
Well, I'm taking kind of a low-tech viewpoint. I think that one of the things we'll see this afternoon, or in the second half of this, is what separates notes from laparoscopy isn't the technology, but I think it's the point of access, in the sense that it's just something that's different. And I think we need to kind of focus on that a little bit, in the sense that this can be done in the ICU, it can be done maybe under conscious sedation. And I think that's one of the important factors, so that maybe not trying to duplicate laparoscopy, but rather trying to maximize what notes brings to us in terms of potential benefits to our patients. In terms of doing the PEG rescue, unfortunately, prematurely pulled pegs is such an orphan disease, it's kind of hard. You know, I mean, we have our pagers, we carry them, and about 2 o'clock in the morning, about once a month, we get a call and to come in and see the patients, and it's just a very, you know, not very common concept. I think one of the things, in terms of all the different platforms and all the different technology that's coming along, you know, you bring up the question, when will we be using notes as standard of care? It may never be so much that notes is the standard of care, but all these endoluminal and intraluminal technologies are going to further our advanced endoscopic skills, and that will be a new benefit.
Bernard, have you done more at IRCAD than the first several cases?
Yeah, we're still continuing the human experience, but with all the limitations that I've shown in the talk. So to say when notes will start, we will depend a lot of the technology, and as Paul says, we don't know when it will come. So today we are doing what we call hybrid notes, so combining the basics of flexible endoscopy plus some of the laparoscopic instrument and tools. Probably there will be a step between the laparoscopic surgery and the true notes, and this step is the hybrid using flexible instrument and maybe the single port surgery. We don't know. So we are working step by step and still facing a lot of technological problems for doing true notes surgery.
Santi, you probably have the largest UX experience now, I think. Any thoughts?
Yeah, we do see a difference, you know. In the US, convincing a patient to undergo notes is much more difficult than when I go to Argentina. It's clearly easier. The issue is how can you duplicate? And as Marta Lamini says, our job is to develop, but then be able to duplicate this along the line. And I think that this panel can do notes, but it's very difficult to duplicate that. And the challenges are in technology. I think that there is no doubt that the transvaginal approach is going to be a great approach, as Bernard was saying earlier, with the aid of a grasper through the abdominal wall, either 2 millimeters like we did for our appendix, or 5 for the lap chole. The outcome seems to be a little bit better. Transgastric, I don't know. Maybe what we developed there is going to enable us to do more endogastric and single incision surgery through the belly bottom, and that's the way we are thinking, and it seems to be the panel.
Danny, any final thoughts before we...
Yeah, thank you. Short answer, 5 years. I'm a diehard believer that this is the next evolution or revolution, depending on your perspective. And I think it's going to get there, but it's so technology dependent. I mean, embedded in each talk this morning, you heard about the hurdles and the technological solutions that are being attempted. But compared to the real enthusiasm we had in this field 2 years ago, where everybody thought next year people are going to be doing this, we've learned those lessons, and there is kind of a plateau phase while the technology catches up with the vision. And I agree with Bernard's comment. I did my first Sills lap band this week on a BMI of 48, and it was tremendously easier than all of my notes work combined. And so I think single incision might be that transition point for us in the near term.
Question from the floor.
Hi, Sérgio Wall from São Paulo, Brazil, Syro-Libanese Research Center. Just to clarify one comment from Dr. Christopher. In Brazil, notes is not a reality. Most of those cases are doing without R&B approval. There are more than 2 or 3 deaths in Brazil, and I just want to clarify this. I'm doing notes in a lab more than 3 years, and I don't have my R&B approval until now. So notes is not a reality in Brazil and in most of the Latin countries. So please don't have a wrong idea and don't tell all the communities the wrong idea. So notes is not a reality in Brazil.
I think we'll hear from Ricardo Zorin this afternoon about 158 patients that were done in Brazil as part of one registry. 158 patients is a considerable experience we can learn from. It is hybrid notes, and I think it's something worth discussing.
No, I think your comment's important. One of the concerns people have is underreporting of the complications. That's useful. Yes.
Hello, I'd like to ask the panel to answer the following question. When we made the transition from open surgery to laparoscopic surgery, it didn't appear immediately obvious as to open surgeons what the benefits were. Clearly, those benefits became obvious. Lack of abdominal wall incisional hernias and complications, a reduction in comorbidities, and improved and reduced time to recovery. What do you foresee as being the true benefits to the patients from an approach that doesn't use abdominal incisions, that uses natural orifice surgery? What do you perceive, what do you predict will be the benefits that we'll be able to measure other than the cosmetic ones?
Let me take a crack at that one rather than asking everyone. I get a chance to talk to a lot of people, so the one thing that impressed me, I have the same skepticism initially that you've expressed. What I have heard uniformly is that the amount of pain that the notes patients, humans, have is significantly less even than laparoscopy. I think we should be fair when we talk about recovery from laparoscopy. Yes, our patients who have a lap coli can go home in 2 hours, but how many of them really went back to work the next day or 2 days later? Honestly, you answer that question, turns out they go back a week, 10 days, 2 weeks. It depends on what kind of a job they have. But if you operate on one of your physician colleagues, for example, or you operate on a high-powered attorney, someone who's highly incented to go back to work, they really, in my experience, most of them cannot. If you did them on a Wednesday, they go back Monday at best, and they don't feel quite right. And this is different than what I'm hearing from colleagues in South America, from Santiago, and from Soper and Swanstrom and other people who have done this. So there may be something to it in terms of the disability. And if anyone has something to add, please go ahead. But it's been striking to me in Asia, in South America, and in the US. Without prompting, I've heard this story 15 times.
As a gastroenterologist, I'm also thinking about how other procedures might benefit patients, such as palliative gastrojejunostomy and pancreatic cancer. If you can reduce that recovery period for someone who has a very short time to live and get them out of the hospital sooner, I think that would be a clear advantage. And other patient populations may be good ones to target, such as the morbidly obese. Giving them another procedural alternative with lower complications might be one way to go.
All right. Paul?
I think that doctors actually undervalue the advantages of cosmetic result for patients. I mean, patients actually hate scars, and I think that they're right to do so. And if we can do operations which actually are free from scars, they would actually much prefer, and they're right to do that. The problem is that we can't yet do it more safely or more quickly or better. But I think that it is a real aim, and patients really would like it. So, and I think that doctors who think the laparoscopic scars are nothing, but I know that in fact patients actually hate scars, so I think that's important. I'd also like to make a pitch about MRSA. In the UK, that's sort of a plague, and you won't get MRSA if you go through the wall of the stomach or probably through other orifices. You may get other things, but you won't get that. And the third thing that I'd like to say is that even if notes as an adventure is a complete failure, for the device development, will actually be enormously important for other things. So, and both for the flexible endoscopists, we'll actually get instruments for flexible endoscopy that actually do surgery and work. So we'll get things that stop bleeding, which we don't have at the moment. We'll get things that cut. We'll be able to close perforations. We'll be able to do EMRs better. And that would just be great for patients. But also the laparoscopic instruments will change. You will see that people are being forced to try and react to notes and develop single port access, laparoscopic smaller instruments. And this is actually good for the patients. So even if the notes doesn't work, I think good will come of it for patients, and that's what's important.
Santiago?
Yes, and to reinforce what was said, the patients that we did in the US, all of them went to work within 48 hours, and we have proof of them because some of them were at UCSD. And so we know that they have less pain, and we know that the recovery is faster if you diminish the size of your incision in the belly button or in the area of the abdomen. And the second issue is to reinforce what Paul just said. Maybe not so true in the Midwest, but when I moved to California, scars are an issue, and belly button is important, and it's as important as pain. And patients are seeking physicians who are not making incision because they want a good cosmetic result. And we have underestimated that in this country, not so true in Latin America or Europe, and I think that now patients are wanting that. So we need to deliver.
All right, thank you very much. We're going to resume in 5 minutes officially.